Yes.
Thank you, sir. Good evening to everybody. First of all, I convey my sincere thanks to organizer of the first annual conference of Indian College of Physicians West Bengal chapter for inviting me as a speaker here. The case has been put to me is a 45-year-old lady with the absence of left-sided radial pulse. But as I have no so much ready with this type of case, so actually I here present as a how to do you approach in a case of a 45-year-old lady with the absence of left-sided radial pulse. First of all, you should first you confirm that whether the left-sided radial pulse is really absent or it is diminished. It is difficult to palpate, it is steady, weak, like that. So first, I will say my postgraduate or my that you first confirm the whether really it is absent or not. Second is what are the causes? Think of what are the causes of absent radial pulse. And it is first cause is usually though it is another is a anatomical abnormality, congenital anomaly or abnormal aberrant radial artery maybe is one of the cause. Is it tired of surgery of the previous surgical cut down that you have to take the history of any previous surgery? In the catheterization of the brachial artery, usually done in the right side, but it may occur in the left side, that may cause as the complication of absent radial pulse. And following a radial artery line for monitoring the blood gases or arterial pressure measurement, that may be complicated and produce such. That is associated with subclavian artery stenosis that I am coming later, and that may be due to some post-operative complications like a or post-operative sequelae like a balloctosic shunt in a case of a tetralogy of Fallot, and embolization of a radial artery usually caused by the atrial fibrillation or any other thrombophilic disorders, or after in a post-COVID state, you may get such type of embolism in the radial artery. And it may be due to some not due to total absent, but maybe the inequality or a like a very much weak of amplitude of the peripheral pulse, particularly left-sided radial pulse. That may be due to some obstructive arterial disease due to atherosclerosis. It may be associated with the aortic dissection or aneurysm of parts of aorta. There may be associated with a Takayasu arteritis or aortic arch syndrome or pulseless disease, the same nomenclature, or it is associated with the other large vessel vasculitis, and it may be associated with the coarctation of aorta, mainly the pre-subclavian coarctation, and disease that can also affect the aorta, that may be some Barger disease or some vessel that I'm coming later, and it is maybe due to some thoracic outlet obstruction, cervical rib, and also supravalvular aortic stenosis, in which the right carotid, brachial, and radial pulse are larger in amplitude in volume than those of a left side, because the preferential shunting or streaming of the jet towards the innominate artery in the right side rather than left. That may cause the weak of the left radial artery pulse. And maybe the pressure over the axillary artery by the lymph node. So these are the causes of absent of the left sided radial artery or very weak left radial artery pulse. So before going to subject proper or clinical examination, you should have an idea about the anatomy of that, because right-sided subclavian artery is a branch of the brachiocephalic trunk, but left-sided subclavian artery is coming from directly the arch of the aorta, and there may be a pre-subclavian stenosis is there, and there may be a subclavian Steele syndrome is there that I'm coming later. So these are the other possibilities to cause a very weak left radial pulse. So this is the left subclavian artery that turns into a left axillary artery, then left brachial artery, and it is divided into left ulnar and left radial artery. So the pulse is absent is here, left radial artery. So how to what are the points to be taken in a history when the patient comes with a left-sided radial artery absent pulse. There is a past history, taken the history of a past history of insertion of arterial line for blood gases of arterial pressure. There may be some symptoms, rather systemic symptoms, some conventional symptoms that may be associated with a arteritis or other vasculitis. There is a past history of cardiac surgery you have to take, and there is history of a neck pain or any history of a claudication in the cervical rib due to cervical rib, or any history of a thrombophilic disorders. So you have to go ask for the about the symptoms. I have already mentioned that any conventional symptom, particularly the malaise, weakness, and fatigue and fever, and any arm numbness or claudication, particularly upper extremity claudication, is much more in the Takasu rather than a lower extremity. This is associated with lightheadedness and episode of syncope that may be due to the associated with this aortoarteritis or any vasculitis. The chest wall pain or joint pain associated with other autoimmune disease that may be associated with weight loss or any neurological or cardiological complication, or associated with the ulcer, gangrenous skin changes, and nail bed splinter hemorrhage like a subclavian associated with the subclavian artery stenosis and arterial embolism. So this may be the cause of left-sided, artery pulse absent there. So you have to take the past history and you have to take the treatment history. That is most important. After taking the history, you have to examine the pulse. The patient is already given that the left radial pulse is absent, but you have to check the other pulse like a carotid, radial, rather femoral, posterior tibial, dorsal pedis, routinely examined bilaterally, and to ascertain any difference in the pulse amplitude, contour, and obstruct. That gives a help in differentiate aortoarteritis rather than local block. Popliteal pulse should be examined when the lower extremity arterial disease is suspected, and the brachial artery pulse is examined to assess the volume and consistency of the peripheral pulse. That is most important, whether it is a localized radial pulse is absent or brachial arterial pulse is also diminished or it is present. If the weak pulse is present, rather palpable, then you have to check the what is the rate. If the discrepancy of the rate of the two arms, like right arm and left arm, is more than 10, or blood pressure discrepancy is greater than 10 millimeter mercury in systolic or 5 millimeter in diastolic between the right and left arm, and that is a significant, and that gives the clue that it may be associated with the either subclavian artery stenosis or any associated with the aortoarteritis. So in which condition may pulse rate is one arm is differ from that of others. So usually slowing of the pulse rate from one side occurs distal to there is the aneurysmal sac. If it is a pulse rate is different, you think of there may be some aneurysm in the arch of aorta. If the aneurysm is in the transverse or descending aortic arch, then the left-sided pulse will be feeble and left pulse will be maybe the absent. But if the aneurysm in the ascending aorta, then maybe the pulse changes will be in the right radial pulse. So as our patient is a left radial pulse is absent, you think of maybe the associated with the aneurysm in the transverse or descending aortic arch. You have to check for the radiofemoral delay. You know the simultaneous palpation of radial femoral pulse is important. Is there any delay? You have to search. In normal adults, the upstroke of radial and femoral pulse, you have to palpate simultaneously, and you can see that both the pulses normally appear simultaneously. And if there is a delay in the onset of the femoral pulse, generally associated with the diminished amplitude, suggests that it may be the coarctation of aorta. So if there is an associated pre-subclavian coarctation of aorta, then maybe you get the left radial pulse is very weak or very weak. So you have to check for the blood pressure. Is there any discrepancy of more than 10 millimeters in the right and left? Because asymmetric arm blood pressure is 15% present in a Takaisu arteritis. Unequal arm blood pressure eventually develop to half of all the patient in a Takaisu arteritis. So undetectable pulse in the left arm you have to check for the what is about the right arm, and you have to check for the left brachial pulse. I have already mentioned, and you have the whether it is associated with the hypertension or not. If the patient is associated, usually 20% patient of arthritis is associated with the hypertension, and that is due to the involvement of the renal arteries also associated with renovascular. But if the difference is more than 10, is narrow 15 or like that, that may be associated with the subclavian artery stenosis. So commonly, these are the common in a female. It may be a case of Takayasu arthritis, but Takayasu arthritis is a disease of vasculitis that commonly affects the aorta and major branches, and it is frequently common in the young women, and affects the women is 8 times more frequently than men, and median patient age is 25, but our patient is 45 years. But 10 to 20% patient of Takayasu arthritis is seen after the 40 years. So there may be a chance to develop Takayasu arthritis. In this case, here is the age is 45, though the Takayasu arthritis is a more common in less than 40. So reduced or absent pulse is 25% in Takayasu arthritis and associated with the carotid bruit, hypertension, and others. There may be history of claudication, and many young female, mainly they complain of arm claudication first reveal when they use hold a hair dryer. So in this way, they may give a complaint to the doctor, that the patient may complain of pain when they are using the hair dryer by the left arm, because they are using they hold the hair dryer by the left hand, and that's why they complain this type of claudication. And if they complain, you have to check for the pulse BP of this patient. So this may be the one of the presentation. So you have to check for the cardiovascular examination, and particularly heart and aorta is the primary source of arterial emboli. If the patient come with a suggestive of arterial embolism, but bruit is the most common sign, and that you have to examine in case of a Takayasu arthritis, because it is eventually found in 80% cases of Takayasu arthritis, and common is the carotid artery bruise. So if the patient you have a rather weak or absent pulse in the radial artery, in the left side radial artery, you have to put a stethoscope of the carotid artery, and that is a much more common, and also in the subclavian area, mainly infraclavicular area or axillary area, you may get a bruit over there, and that gives the clue that it may be a case of a Takayasu arthritis. Cardiac involvement is also common in this patient, so you have to examine the heart. So aortic regurgitation is a much more common in case of 20% cases as a result of aortic root dilatation. And aortic regurgitation is important because it frequently progresses and may lead to left ventricular dilatation and secondary mitral regurgitation and congestive heart failure. But really, you have to search for whether it is associated with a aortic arch involvement or not, because aortic arch involvement is a common in other diseases also, apart from Takayasu arthritis. That is most important. And for them, you have to check for the blood reports. I am not going details about that, because you have to do the CBC. Whether the infective cause is there, is the platelet count is important, whether it is associated with autoimmune disorder. And in ESR and CRP, at presentation, ESR is more frequently elevated 80% than the CRP in Takayasu arthritis. Do I have to do a blood culture? I mean, VDRL, because syphilis and tuberculosis is also associated with the weak or absent pulse in the radial artery. And autoimmune markers and antiphospholipid antibodies you have to do to exclude any vasculitis or thrombophilic disorders. You have to do the imaging, particularly chest X-ray, ECG, echo, and echo Doppler study, and ultrasound Doppler study, CT angio, MRI, and MRA, and also cardiac catheterization and conventional angiography. If required, positron, even a PET scan to be done to see whether the associated inflammation is there, particularly when the inflammatory vasculitis when you are suspecting. So with this, you have to check for whether this patient is associated with the Takayasu arthritis or not. And in this case, though the patient is about the 45-year age, then check for the history of limb claudication, decreased brachial artery pulse, and unequal arm blood pressure, and subclavian or aortic bruit, and angiographic evidence narrowing of this occlusion. These are the presence of 3 or more of the 6 criteria is sensitive near about 90% and specific 98% for the diagnosis of the Takayasu arthritis. So you can use these classification criteria and apply to this patient to diagnose the case of Takayasu arthritis. So these are the clinical features of that. These are the clinical features of Takayasu arthritis. And so you have to check for the other central nervous system that I've already mentioned to you. And the frequency of blood vessel involvement in Takayasu arthritis subclavian vein is the 93%. So you may suspect that this case may be a case of a Takayasu arthritis. So though the patient is more than 45 years age, but in a case of algorithm in a diagnosis of Takayasu arthritis, age is less than 40 years and symptom and signs of large artery or bruit or loss of pulse or history of claudication is there, you have to do an image of aorta and major branches. If it is abnormal, is there any evidence of disease of aorta or branches other than Takayasu arthritis? So if that is no, then you can diagnose this as Takayasu arthritis, or if that is not there, you can diagnose of other diseases. What are the other diseases? You may because that Takayasu differential diagnosis of Takayasu arthritis or other diseases that can affect the aorta and that can affect the large arteries, particularly, I mean, the brachial or radial artery. This is a giant cell arthritis that is important, particularly old age, Barger disease, and also atherosclerosis, rather Marfan, and also IgG4 related disease. So you have to differentiate the diabetes versus Takayasu arthritis, and you have to exclude the subclavian artery stenosis mainly from the history and also examination of the pulse, and it is mainly the disease of the old age. And you have to exclude the disease of arterial embolism, particularly pain, loss of rather a sensation, and features of rather a any gangrenous change will be there, or elevated WBC that may help you to diagnose the arterial embolism. So in conclusion, in that case, maybe the first diagnosis should be a Takayasu arthritis, that it may be a subclavian arterial stenosis, arterial embolism is associated with the gangrenous feature, or any history of surgical intervention in the past. So these are the 4 differential with keeping in a Takayasu arthritis in the first, and that is maybe the case. So as I have no real case in my pocket, so that's why I have rather described as well what should be the approach in a patient of 45-year-old lady with absence of left-sided radial pulse. Thank you again.
Thank you, Professor Ghosh, for your detailed discussion.